Hi, I'm Dr. Bill Adams, and this is an Aesthetic Society Roundtable. I'm really excited on this topic. We're talking about a surgical algorithm for management of implant exchange in patients with textured devices. And I've got three incredible experts to share their insights. So Dr. Louis Strock from Fort Worth, Texas, my neighbor, and Dr. Brad Calobrace from Louisville, Kentucky. And then joining us virtually all the way from New Jersey, Dr. Caroline Glicksman. So ever since the BIA-ALCL recall and then the removal of many of the macro texture devices in the past year, there's been a lot more patients coming in to see us with concerns with their textured devices and what should they do. So that's what we're really going to talk about. So Louis, and I'd like each of you to comment. I'm going to start with you. Should textured implants be worried?
So, Bill, first, thanks for having me as part of this. I would say a couple of things. At the end of the day, it's all about information, and I think that the key is for us to help communicate with our patients in a way that the thought processes are based on information as opposed to word of mouth in the public, et cetera. I think that as long as these patients keep in touch with us, I think they're safe. We typically are not terribly aggressive about just recommending removal in the absence of problems, in the absence of swelling, in the absence of contractures, all these other things. So I think the most important part of the whole issue from my point of view is to really try to have a good conversation with the patient about all the issues so we can figure out together exactly how we're going to manage this without ever having the appearance of trying to take advantage of someone's anxiety.
Brad, your thoughts?
Well, I think that there's probably still a place for textured devices. BIA-ALCL's gone now, so we don't have to worry about that level of macro texture. We don't have polyurethane, so we really just have a couple other textures to use. That being said, in the United States, we've always been a smooth world, unlike the rest of the world. So smooth implants we've been comfortable with. We use smooth saline implants and we went to smooth silicone implants. So I must say, although I did a trek through textured because we had some good textures that we could use, and there are some significant advantages, today I sort of slid back into using almost exclusively smooth devices because of all of the issues related to texture. So safe, and can you use it if you really need it? Yes. What I'm finding is I'm just needing it less and less because of the newer implants. We can get good results with smooth devices.
And Caroline, how about you? When your patients say, Dr. Glicksman, should I be concerned? What do you tell them?
Well, I think we had to be proactive in all of this because there's a lot of information about texture in the social media world before Allergan even came out and did their recall. So one of the things that some of us did is I always sort of follow my patients. They're given appointments every 2 years, and I've been really a textured user for almost 30 years. So I've got a huge number of patients who have texture. Reaching out to those patients with letters in advance of the FDA hearings gave them a heads up so there wasn't a panic in my office. And then just continuing to see those patients, having an ultrasound in the office, following them, providing them with the necessary information, the tools to make a good decision. Do all textured implants have to come out of these patients? Well, there's no data on that. Clearly, there's no data, and the FDA also says that they do not have to be removed. But there is anxiety, and there is other risks that patients have, and there's also, obviously, implants all rupture. So then we get into the decision of when do we want to replace them, who's paying for all of it. There is it's sort of a warranty that helps with part of it, but a patient with a 3-year-old textured implant who loves their result may not have the money to spend right now to replace it. So there are a lot of issues, but the most important, I think, is when that patient walks out the door, knowing that they know the signs and symptoms of a problem. Yes. And so that they get in there early, because this is a curable disease, ALCL. So it's something about educating your patients, keeping them in your practice, keeping them well informed.
So, and speak to that just for a minute too, Caroline. What are the warning signs? What are the things that you tell your patients, hey, you need to be aware of this? And because awareness, like you said, that's the key. So what are the things you tell your patients about that?
Well, I tell my patients, obviously, a sudden onset of swelling, something that it can't relate to trauma. It could potentially be just a late infection, of course, and a benign seroma. But a sudden onset of swelling, teach them how to examine their breasts. What is implant? What is breast? And what is muscle? So that they can get a basic idea of how to do a self-exam on themselves and to call me with any problem in their breast. So obviously it's a sudden onset of swelling. They also say a change in the feel, suddenly something different about the breast, a rash. We know that there are some patients that do present with a rash. So those are the basic three, and anything, obviously anything abnormal at their radiologist, radiology appointment or GYN appointment.
I'm going to switch back to the original algorithm topic. Now I know Brad and Caroline, both of you have some algorithms that you use in management of these patients, and algorithms are things that we've used in many different areas of surgery. It helps us as surgeons just kind of codify things into steps in management decisions. So I want each of you to make some comments. Brad, I want you to talk about the algorithm that you typically use for these textured implant patients.
Yeah, I think whether we do it formally or informally, we have algorithms in our mind. But when you get to revisional breast surgeries, there are a lot of decisions that we're making, and it relates to what to do with the capsule, what to do with the pocket, which implant you're going to place, do you need to do a mastopexy? There's so many issues. And I've just found with my fellows that they have a hard time knowing which one to prioritize. So my algorithm prioritizes it for me. So when I'm thinking about somebody having an explantation or an exchange, the first thing I want to know is whether they're going to have a new implant placed or not. Are they comfortable with implants? Do they need an implant? Aesthetically, what are they looking for? And it sets me on my algorithm. That's the first place. Beyond that, once I know which path we're going down, am I going to keep the capsule and modify the capsule in some way, or make a neosepetral pocket and use that capsule, or for some reason am I getting rid of the capsule? And that's true whether I'm putting an implant in or not, explaining and not putting an implant in. And then finally, once I've made that decision on my algorithm, it is finally, so now what is the breast going to look like, and what am I going to do? Do I need to do other things? Fat grafting, mastopexy, auto-augmentation, and then I put that in the algorithm to finalize it. So I think by doing that, I know where I start. I start with what I'm going to put an implant in, I'm going to start what I'm going to do with the capsule and the pocket, and then finally, how am I going to reshape their breast and make it look good? It just makes it more simplified for me, so I make sure I cover all the things that are concerning when I'm looking at an explantation patient.
Great. Caroline, why don't you talk a little bit about the algorithm that you're using?
Well, basically, I don't want to repeat everything that Brad just said because we think along the same lines. And again, it's whether or not that patient is keeping that implant or not. Again, we're talking primarily about texture here, which changes things a little bit. But the main reasons I would do a capsulectomy, a precise capsulectomy, as we'll say, haven't changed. Capsular contracture, a ruptured device, maybe a potential history of infection. I'm always, for all these years, I'm not putting a brand new expensive device into a contaminated or a problem pocket. So that's the first reason to do a capsulectomy, if ALCL wasn't even on the table here. When it comes to actually thinking about removing the implant, there's some other removing the capsule, there's some other issues. We have patients who have a self-reported BII. Okay, so we have that huge category of patients who are now presenting to our office, and we have patients who have anxiety over BIA-ALCL. So those are two patients who may be requesting a capsulectomy that you might not have done in the past. So I include those in my algorithm, having a good discussion with those patients, and then thinking about whether or not I'm going to be doing a capsulectomy on a perfectly normal, beautiful result that happens to be 7 or 8 years old. The patient got the letter, they want to replace to smooth. Am I going to do a complete capsulectomy with no history of a problem, an ultrasound that's perfectly normal in my office, no radiological evidence of rupture, the placement, the position, they're a happy patient? There are some risks, both aesthetic and medical, related to doing that capsulectomy. So on those patients, I will make that decision with the patient if I'm going to leave that capsule, as there's no indication, no data to support that it has to come out, that capsule has to be removed. So that's in my algorithm as well, because you can do a lot of damage to a very beautiful result in a very happy patient with an unnecessary capsulectomy. So I have to consider that as well at this time.
Okay, so and I want to expand on that. Lewis, I'm going to get your comments. So this is mainly on capsule management. So the patient has no problem, everything's normal, ultrasound, all of that. The patient's just concerned about risk for ALCL, and they have got to have a texture device. What are your thoughts in terms of what your options are? What do you tell your patients?
So I like to have a discussion with a patient, and usually 2 discussions, to run through the information, a lot of which Caroline just went through, about the lack of medical indications and the potential harm done by an unnecessary capsulectomy. So I tell the patient, if there's anything abnormal, I'm going to remove the capsule. But if it is absolutely normal, then typically I'm not going to perform a capsulectomy, and I've got to be confident that the patient understands that and is accepting of that, it effectively ultimately being a game time decision in the OR about that. The other issue really, I just really want them to also understand that the added inflammation, potential healing issues, bleeding risks, other issues about a capsulectomy, plus it can be very important building material because a capsulectomy will always result in a larger implant pocket, almost always. So that there are clear negatives, and it's my job to explain that to patients to counter what they may have heard from friends or on social media that might be partly correct and partly incorrect about that. So that's how I approach it, and then I will decide in the operating room. If I leave the capsule, particularly with BIA-ALCL, I video it and give it to them. They can have it if they like. But I make very clear if there's any abnormality noted, then we're going to remove the capsule, and that discussion is different.
Yeah. And then, Brad, how about you in terms of an abnormal capsule? Then you're going to remove it.
Right.
So talk to me about two things. One, we talk about total precise capsulectomy versus what people call en bloc capsulectomy. So talk to us about that a little bit.
Well, you know, as Caroline mentioned, you know, prior to the risks of ALCL, you know, I had sort of, most of my capsular contractures were treated with a total capsulectomy. But definitely, if I ran across a calcified capsule, a mass in the capsule, silicone embedded in the capsule, I had certain indications where now I totally want to do a total capsulectomy, whereas sometimes I would leave part of the capsule because I'd be trying to control the pocket, or they had very, very thin skin envelopes, and I'm judging the balance between that. Now you're dealing with this idea of this unknown future risk with lymphoma, and you're trying to treat that. So you're balancing that risk now, especially because you want to have the benefit without the risk. We're not sure what the benefit is. We know you can conjecture that potentially it minimizes or reduces the risk. I don't think we can say definitely that it eradicates the risk of a future BIA-ALCL. So for me, it matters what pocket they're in, because if they're subglandular, then that's going to be a much easier dissection. I'm going to be much more likely to recommend we just take the total capsule out. It's going to be a much easier, much safer operation. It's when you have a submuscular implant with a capsule, especially a very, very thin capsule, very hard to even be able to guarantee that you're going to, in a safe way, be able to get rid of that capsule completely. And so I'm just very transparent in that conversation with the patients that I have their best interests at heart, and that we are going to do our very best to do a complete capsulectomy, but this is not an en bloc capsulectomy. I do think patients get confused because of social media and all between an en bloc capsulectomy and maybe an en masse capsulectomy, which just means they want to have everything taken out. They want the capsule and the implants, as much as you can, take them out together, try not to spill contents. An en bloc capsulectomy, by definition, is a malignancy because it says you have to get a negative margin or a clear margin around cancer as an en bloc resection. And since you don't have cancer in these types of cases, you're not really doing en bloc, because what is your margin around? Normal tissue. So I think that we should not use that term, and that it's not at all costs take all the capsule out because a patient has concern. It's when I can do it safely, I do. If I can't, I take out most of the capsule and do something to sort of obliterate or eradicate the remainder capsule safely with cauterization or whatever anybody wants to do. I do cauterization. And I think that is just as effective, at least from the literature, it's just as effective as putting the patient at risk of a pneumothorax, hematoma, et cetera.
Yeah. Caroline, I want you to address specifically, if you have a patient, so for example, let's say they have capsular contracture, you're doing a total capsulectomy. Recently, there's been a lot of spread of what I would term some misinformation on a lot of social media sites that you're supposed to send that capsule for CD30. And I think that's mixing up two different things. So can you speak to that? What should surgeons send a capsule for, say it's for capsular contracture, or if they're just doing a capsulectomy specimen because the patient requests it, what should it be sent for in terms of a lab evaluation?
If it's just a routine, implant exchange, and the patient has a self-reported BII or whatever, that's their reason, or you're just removing for capsular contracture, routine, no previous history or a risk here of lymphoma, then if you if the patient has insurance and they agree to it, because they will get an out-of-pocket bill quite often, it's an aesthetic procedure, I would send for routine histopathology. You know, if you have a concern or if there's any fluid identified, obviously you're going to send that off to rule out ALCL, CD30, ALK negative. You want to, you know, list on there specifically rule out BIA-ALCL. I think most pathology labs now know exactly what tests to run. Sometimes there's a battle between the insurances, whether or not they'll do flow cytometry or they'll do cultures, and you get that discussion and you get that from your local lab that the patient's benefits don't cover both. So you have to be specific on what you're sending if there's a suspicion. If there's no suspicion, then you're just sending that specimen really for routine pathology. That's going to be an out-of-pocket. You can negotiate fees with your local labs. But this comes up a lot when a patient asks for it to be sent. You say, well, what am I sending for? And you have to justify that with, you know, payments. So that's one issue. The other thing I just wanted to mention briefly was that a lot of what we discussed today is very fluid. What we're saying right now, that we don't send capsules on everybody, I may not be doing a complete capsulectomies on everybody, may change as the data changes. There was an anecdotal report of a mass that was found in a capsule. There was an ALCL where there was never a seroma before. You know, you get those kinds of stories. Some of the big tertiary centers are doing capsulectomies on all their patients that they do implant exchanges. You know, places like Sloan Kettering or maybe MD Anderson, the big centers. So patients get that information, but I think they have a different experience. But I just, number one, think that you have to be, whatever information we give out today, it's constantly changing, and reading the journals and keeping up with what may change 6 months from now based on the information that we get from more research.
Yeah, the only thing I'd add to that is just, you know, we've been guided by Dr. Marshall Caden, who's a renowned dermatopathologist who actually described cutaneous ALCL. And what he says is that when we're sending, say, a total precise capsulectomy specimen, you send it for the histopathology. Actually, the pathologist looks at that. The key, and actually the truth is, even in fluid, we send CD30, it's a marker for activated T cells, but what's really important there, again, is that what the cells look on morphology. So when you send a full capsule specimen, they look at that, and if the pathologist sees something there that indicates other testing, then they will do that, but there's not really any utility to sending CD30 when you have a full capsule specimen, because they're going to be able to look at that under the microscope.
To that is that I think they get confused often when they see the pathology of fluid, that when they see a CD30 positive, that means, oh, my patient has
That's right.
BIA-ALCL, and that's not true. Like you just mentioned, you need monoclonal expansion of that T cell in large anaplastic cells for it to make a diagnosis, because a little bit of CD30 is pretty normal in those things.
Yeah, actually, Ariana Di Napoli showed that about 10 to 12% of seromas are CD30 positive but negative for any malignancy. And actually, Caroline has a publication as well that has shown the same thing.
Published on that, yeah, several years ago.
And Caroline. So Lewis, let's talk about this. Now you're in the scenario where you're doing, let's say you're doing a removal, you're doing a capsulectomy because it's been decided, and you're going to replace an implant. I think sometimes people think that's a lot easier or simpler thing than it can be, number one. So kind of what are your thoughts on that? And then also I want all of you to kind of address maybe the concept of, do you do anything else, support other things? So what are your thoughts?
So after you've done a capsulectomy, invariably you're going to be dealing with an implant pocket that is larger than it started. The one exception to that's the very highly calcified patient that we sometimes see that the capsule is contracted, that it actually isn't larger. That's kind of the easiest case of this group, but most aren't like that. So you have to control the periphery of the pocket, preferably by some markings you've placed externally, preoperatively, reestablish the inframammary fold support, and then the lateral, particularly the lateral extent of the implant pocket. Depending on the implant that's going to be used, I'm a big fan of reabsorbable biologic meshes, something like P4HB that I've used quite a bit to attempt to add improved tissue support, particularly if I'm using a more projecting implant. So something like a soft touch full profile device, for me, I won't do that without mesh in a secondary case, for example. So I'm a big fan of support because ultimately I think that the success of the aesthetics of that kind of scenario really depends on stabilizing the inframammary fold both inferiorly and laterally. So to me, that's kind of the way to think about the implant pocket post capsulectomy. You have to regain control of that space somehow. There are other ways to do it. That's just my preferred technique.
Yeah, and Brad, the tough thing is that, like, for example, a patient with capsular contracture, they don't like having a firm breast, but their breasts are up and kind of high, and then they feel like they go from that to just a saggy breast, and they hate it. And so what are your thoughts on that situation?
Well, there's a few things. I do believe that if they're a textured saline, this can be a lot helpful to deflate them initially. A month before, I just did a case like that last week. So I think anything you can do to shrink the pocket beforehand, or if it's really a situation where they're looking for something like that, and I don't think I can control the pocket adequately, it's very acceptable to do the capsulectomy and stage it and get that cleaned up, let this soft tissue shrink, reassess, and then come back and do it. Because I think one of the issues you have to always address with the patient is, what are they aesthetically going to look like if you take out their capsule and they're not having an implant replaced? And that's really hard to describe to them. You try to show them pictures, but they'd be shocked at exactly, that particular patient you mentioned, exactly how ptotic their breasts really are when that calcified capsule, subglandular capsule is gone for that. So, I always remember that I can always stage them, or I can pre-deflate the salines as some of my options. But other than that, I agree here. I think that, I try to, in that first operation, deliver a beautiful breast if at all possible, whether I'm using mastopexy, putting a new implant back in place, doing auto augmentations. And if I can't control the pocket with simple pocket control sutures along the lateral border, especially in a fold, then I place P4HB, just as Lou mentioned as well, because I think it can be very helpful at supporting the pocket.
Caroline, any pearls to add to that scenario?
You know me, I'm going to go back to the regulations here, but I'm going to basically just say that we have to remind ourselves and our patients that currently, the use of any soft tissue support in the breast is completely off-label use. There's no indication right now for soft tissue support in the breast until the manufacturers finish their clinical study. So you have to educate patients about that. I think you have to be really careful, because the FDA's made a big stink about that now. And so, if they're going to pay for it, and they're going to have to maybe potentially have a little bit more of an additional informed consent along the way here now, because it is well known that there's no indication in the breast for these materials. That being said, there obviously, there are times when you're not going to be able to get the soft tissue support you need by suture. We know that doesn't work, that these products are out there. The resorbable ones, obviously, like the P4HB, it's a beautiful material. There's no education or teaching around them right now because they are off-label. So it's hard for young surgeons to learn how to use them. But these products are out there. If you're doing an explantation, for me, if I have a saline patient, if I can deflate them and stage them, boy, you get that heads up ability for them to, know before they go what they're going to look like. So they get an idea of what we would see in the operating room. So obviously deflating them or staging them if they can afford it and they're willing to do that. I think that's great. Like you said, the soft tissues contract. So that's a great option. But that's basically it. I mean, using soft tissue support, I've loved it for years, but I'm really wary about using things that are completely off-label at this point.
Last thing I want all you to comment on, but and now in the patient that, if you've gone through all the discussion in the patient, you're going to remove the implants totally. The one thing, Caroline, the patient, well, what am I going to look like if we do that? What do you tell them?
I mean, if I'm fortunate enough that they're my patient, I can go back to their preoperative images. And if they haven't had 6 more children or gained a ton of weight, you can look back at their pre-op pictures and say, well, you were a little ptotic on this breast. Do you mind going back to this? And I use their pre-op pictures a lot. And some of them say, I wasn't as bad as I thought I was 10 years ago. And some of them will go back to that. And then I'll try to say to them that. And I also, for any patient, you can deflate or go back to their old Vectra images. And I've done that too. If you have that can-fill Vectra in your office, I've gone back to their old Vectra images and say, this is what you might have looked like with a mastopexy and not an implant. So it's really amazing that you can actually get just a little bit of that preoperative education if you have images from them preoperatively in your Vectra. So you can play with that a little bit. And actually, really, I just let them make a decision on their size. If they are happy with their size, okay, because that's what an implant does. It really adds volume. They're not going to be happy unless I replace that with fat if they have it. But if they say, no, I've gained weight with menopause, I'm heavy now, I don't mind being smaller, I say, well, then let's take out, you do not need a new implant. And then we work with soft tissues.
When we're talking about removal, no replacement, just talk a little bit about, some other options, like when is it safe to do a mastopexy, when, fat, what are your thoughts there? And then Brad, I want you to comment as well.
So in the patients who ask to have their implants removed, I'm typically trying to assess with them the existing building materials. And it's tough when you're trying to build a house and there are not enough bricks in the driveway. And in the specific context, I'm really looking at having a conversation with them, usually twice, about can they really live with a smaller breast size. And then the other thing I'm really looking at is repositioning the tissue they have. So I tend to be pretty aggressive with the use of mastopexy in this context. An auto-augmentation, deepithelialize a flap and tuck it up beneath inferiorly and centrally to try to maximize what's there, with the caveat that the lateral part of that is often not helpful. But anyway, so to me, that's kind of my primary approach. Fat grafting has a place, but typically I leave that for a secondary procedure to see if is the patient, to the degree to which they're happy with simply having an auto-augmentation mastopexy repositioning.
Especially if you're taking out the capsule, fat grafting becomes problematic, because ultimately it's CEFs, which Del Vecchio described, you leave the capsule, but if we're taking out the capsule for other reasons, then it makes it tough.
To me, fat grafting is more valuable secondarily than at the same time, at least in my hands.
And Brad, talk a little bit about that situation, and are there any patients that are red flags that, you're like, I'm not safe to do a mastopexy in this patient?
That's going to be hard for me because although I do understand the capsule provides some level of support and circulation, when you take that away, probably it matters then to me secondarily whether they were submuscular or subglandular, because that can affect the circulation, the overlying breast flap. Thirdly is how far do I have to transpose the nipple-areolar complex in success? And that's my real get-go. I can kind of handle the other two, but if I'm going to add those two, subglandular, and you got a thin overall flap, and then I feel like the nipple has to go a long way up, that's probably somebody I'm going to stage. Now, I understand that's the exception, not the rule, but I do. I find that, so these postmenopausal women this is a great operation. I'm telling you, explantation plus or minus capsulectomy, some sort of mastopexy, auto-aug, which I do the same with as you do, to give core projection, use fat grafting the periphery. I agree when you take the capsule out, it can be problematic, but these patients often have pretty thick envelopes of breast tissue and skin, and I can get some fat in there primarily. My most problematic patient is the very, very thin patient who wants the capsule out and has a little bit of ptosis to the breast, because now they have skin envelopes. They have no really fat to use for grafting. They're going to be very deformed once you take their capsules and their implants out, and they just have hanging skin, no core projection or way to shape it. That's a particular one that I need to make sure they don't want another implant, because the implant for that particular patient, even if a small one, provides so much benefit to shaping their breast, and I don't have any great solutions for that subset of patients.
Well, you all have provided just a fantastic group of insights for us on this. I really appreciate it. I appreciate y'all's time. And this is an Aesthetic Society Roundtable. If you want to see more of these, you can see it on surgery.org.